It's my pleasure here to introduce my previous PMH colleague, Dr. Andrew Wong Tin Yao. He was the immediate past president of the Hong Kong Society for Infectious Disease. And during the time when he was in PMH, actually, we all together had fight against the SARS in 2003, and he was a frontline doctor doing a lot of things. Now, after the SARS, he left PMH, and he had been the consultant in charge of the infection control and infectious disease management of Hospital Authority and Center of Health Protection before going to private practice in the year 2019. Actually, he had joined our Jim Surgery Medical Biopsy. He maintained his clinical practice in infectious disease throughout his professional career, and his interests include antimicrobacterial therapeutics, travel medicine, HIV, and sexual health, including HPV-related pre-cancer screening, anal pre-cancer screening. So he is going to talk to us the case for screening for anal dysplasia in transplant recipients. Andrew, please.
Thank you. Thank you, Dr. Tong, for your kind introduction, and thank you, Hong Kong Society of Transplantation and Hong Kong College of Physicians, for inviting me to talk today on a subject which is of emergence to the transplant community. And I hope that in this coming 15 minutes or so, I will impart on you a new perspective on that will benefit those of you who are managing solid organ transplant. And as you know, HPV is the most commonly sexually transmitted infections in the world. 40 out of 120 HPV types are genital, of which a dozen of them can cause cancers, with the remaining causing genital warts. HPV is transmitted by skin-to-skin contact, and insertive sex is not needed for acquisition. It is found that up to half of the young people, they acquire one or more types of HPV 1 or 2 years after sexual debut. In immunocompetent hosts, 90% of them can clear the HPV infection within 6 months. The natural history of progression is from infection to low-grade squamous intraepithelial lesions to high-grade lesions, and then subsequently to cancer. But in each step of the way, there were opportunities for regression naturally. It is the persistent HPV infection which will prone the person to dysplasia and then subsequently to cancer. Known important factors include immunocompromised state like HIV, AIDS, and people on immunosuppressants, for example, people after transplant or people on biologics. Smoking has also been identified as a synergistic factor. We now know HPV affect not only the genital areas, but also the anus and oropharyngeal areas as well. Worldwide, anal and oropharyngeal cancer caused by HPV is second and third to cervical cancers in terms of case numbers. Most countries have now seen a substantial increase in the anal squamous cell carcinoma, SCC, and the number of cases is expected to grow over the next few decades. In the US, it's rising at a rate of 2 to 3% per year. In Hong Kong, data from the cancer registry show that the incidence of anal and perianal SCC double in the past 20 years. Please note that females are more affected than males in general by the ratio of 2 to 1. And up to 91% of the anal cancers are caused by HPV. HPV vaccination remains the most effective and safest measure to prevent HPV acquisition. However, the benefit of HPV vaccination is not expected to manifest for the coming decade, and for the vast majority of the existing adults in the community, they are not vaccinated, so they are prone to HPV-related cancer changes. And today is the most opportune time to be updated on these exciting areas in medicine, as there are two very comprehensive meta-analyses published in the last 2 years. The first one summarized the standardized incidence ratio from 8 studies, and the SIR is found to be 6.8 compared to general population. And the incidence rate is found to be 12.3, and as opposed to 1.9 in the general population, that is 6-fold higher. How about for abnormal cytology? It was found in 12.9% in those who had transplant, and people with a high-grade lesion account for 2.4%. How about abnormal histology? It occurs, high-grade lesions or any type of AIN, dysplasia occur in 20%, and high-grade lesion occur in 4%. So another meta-analysis used an unified scale to compare between different studies and found that transplant, which is on the right-hand side, which I highlight in yellow and circle in red, the relative risk actually is comparable to people who had cervical and vaginal cancer before. Of course, compared to HIV positive person who also had who are male who have sex with male, their risk is much lower, but still is much higher than the general population. And they are higher than other immunosuppressor states like SLE or inflammatory bowel disease. And it was found that in this meta-analysis, for people who are over the 6 years of 60, they have a much higher risk, and also in female who had a transplant for more than 10 years, they are at the highest risk. And the years after transplant actually is more important when compared to the absolute age. And as I was asked by many patients before, actually AIN or anal HPV infection doesn't have to be associated with anal cancer, anal sex among women especially. And there's a very nice studies which found that actually the way a woman wipe her genital after urination actually may also impact upon whether they will acquire HPV in the anus. Those who wipe from front to back are 3 times more likely to have anal high-risk lesions. And those who only dab after urination, they have up to 60% reduction in the risk. So for women, actually, as you know, HPV is a field effect. So many times, for example, if their vulva or vagina is also involved, many times there is a very good correlation that they may have anal involvement as well. And there were another meta-analysis published 2 years ago that would show also good correlation between persons of type 16 HPV in cervix and anus. And actually, the role of immunosuppression, they can, of course, they can make the virus persistent and also reactivate. So those who have been reinfected, have been infected before the transplant. And also, it was found that the people, for example, who had failed graft after the transplant, they revert back to dialysis. Actually, their risk become lower because they are not on immunosuppressant. And this is a study from the center where I work in UK. They analyzed the cases that they saw, which is a tertiary referral center in UK, and over 5 years' time, 6% of the patients are known to be pharmacologically immunosuppressed. And these 54 patients, actually 40 of them were women, and up to 70% of them developed some form of dysplasia, and 5 of them developed perianal cancer over the period of time. So what are the screening tools? As we know from the lateral history, there are pre-cancer lesions which we may screen. And actually, for cervical cancer, all of those we know there's a very good program. Actually, so much so that the cervical cancer incidence is much lower nowadays in the U.S. when compared to, for example, oropharyngeal cancer in men. And actually, when cervical cancer program was started, there was no randomized control studies. It was only after decades that they found that the program is useful, you know. And this the procedure that I'm going to talk about is also, you know, built on the screening using colposcopy. Actually, the human anus is very short. It's only like 4 to 5 cm in men and 1 cm shorter in women. It is the transitional zone that is the junction between the rectum and the anal canal, which usually are infected by the HPV and also showing these changes. This is analogous to the cervical anatomy, and also embryologically they are similar. And as far as the perianal area is concerned, it's usually classified as 5 cm around the anal verge. And as far as the terminology is concerned, now we favor the use of a low-grade lesion LCL or high-grade lesion. And in the past, we used AIN1, which is belonging to low-grade, and then AIN2 or 3 belong to high-grade. This is similar to the terminology used for CIN. So these are the cytology, okay? When we do this procedure, we will usually take the cytology first, and then with a swab, and then followed by the high-resolution anoscopy. This procedure actually is now the most commonly performed procedure by ID physicians in the U.S. And it's an office-based procedure, and it uses a colposcopy to use the magnifying microscope to look at the anus and anal canal and perianus, and with staining with the acetic acid and glucose iodide. And for suspicious area, we will do the biopsy. And this is a setup of the room, and I won't. And most important thing is to locate the so-called squamous-columnar junction, where most of the lesions are. And then on the right-hand side, there's a picture of a patient with high-grade lesions, in which you will see mosaic pattern and abnormal vascular pattern with the little dots. And on the bottom picture is a picture of a perianus with the acetal white areas, which confirm a high-grade lesion on biopsy. And so there are various school of thought as far as the treatment is concerned. In some countries, for example, in Australia, they will tend to observe and monitor. And in some countries like UK and US, where I work, they will offer some sort of treatment, either topical or ablative treatment. So if you are interested, you might look at the last year's August issue of a medical diary, in which I talk more about the procedure itself. As far as guidelines is concerned, the American Society of Transplantation in 2009 has issued a guidelines. And this is the only guidelines that I've take hold of, right now, and that suggests that organ transplant recipients should be screened for HPV-associated cancers and appropriate therapy. Of course, this will also include other type of HPV-related cancers, including cervical cancers. Whereas specifically for anal cancer, it is suggested that anal pap test, which is a cytology test, should be performed annually, every year for transplant patients, especially targeting those who had history of receptive anal intercourse, or for ladies who had history of any form of cervical dysplasia or history of cervical cancer, especially vulval cancer or VIN. And for patients, who are subjected to cytology, we have to prepare that they have to have the high-resolution anoscope for further delineation of the histology, because without which we can not confirm whether they are the type of lesions. And also the sensitivity of a cytology is at most 70%. And for my practice, I will also screen them for the HPV typing, and which may help give me a better idea as far as the triage is concerned. Because if I found high-risk virus there, and then I will tend to monitor them more closely, even if I don't find any abnormality on the cytology or the histology. This is what the paper suggests, the kind of algorithm for screening, beginning with cytology first, and then any form of abnormality above ascus, they will suggest to high-resolution anoscopy with a biopsy, and then we will treat high-grade lesions. For low-grade lesions, they tend to regress by themselves, so we tend to observe. But there are also other institutions which may also treat people with low-grade lesions, and also for patients' anxiety. And there are still a lot of area for research. For example, these Australian studies is going to study the transplant patients and their lateral history and how it progressed among the transplant patient, and also what kind of treatment would be useful in case of, also especially people who are already on immunosuppressant. It was found that, for example, people on anti-metabolite immunosuppressant, for example, azathioprine and Cellcept, they're especially high risk. And I also had some people, some ladies with SLE who are on azathioprine. They come up with very severe grade, high-grade lesions as well. And so there are also therapeutic vaccine on the horizon. So it's really a very exciting area. So lastly, all of us know about this so-called Wilson-Jenner criteria for appraising whether a screening program is worthwhile. While some of these conditions are fulfilled from what I have presented, there are some areas which will need further delineation as far as the transplant community is concerned. Of course, it's more well established among the HIV population, where in the US and UK they are having screening, in many of these centers, and also in Hong Kong, where I help PMH to establish the clinic. And the take-home message is that anal cancer is on the rise, and transplant recipients are definitely at a risk group. And there are emerging recommendations for screening. So keep this in mind when you encounter a patient, especially if they complain to you they have some sort of anal symptoms or signs. Don't disregard, as a hemorrhoid, And also, I would like to stress that colonoscopy is not a substitute for anoscopy, because it's not built to look at the anal canal, with that magnification. But short of, all this cytology and histology, as a minimum, I think do regular digital and rectal examination for the patient whenever the patient had signs and symptoms, or more regularly, to detect at least the early stage of anal cancer. So with that, I would like to thank you for your attention and welcome any questions.